resulting in all these other outcomes. So, weight gain, fatty liver, poor mental health. So that's the most important thing, is the poor mental health, it is noted. So that's the psychological part of it. But we just heard a case of Cushing's disease. Yes. So Cushing's disease really can result present with depression, mania, anxiety, bipolar disorders, and suicidal thoughts. And patient can present to the psychiatrist. And number 2 is the most important thing, the ICU case, if you remember, acute discontinuation of steroids can result in severe psychosis. We have been called multiple times to neurosurgical unit for psychosis and hyponatremia and hypotension with adrenal crisis. So that's something I want you to have in mind. And parathyroid, so often people have never thought about thyroid. Calcium has a major role in mood disorders. Either hyper or hypocalcemia can cause both. And hypocalcemia, usually it's so chronic, it's never in a thing. But hypercalcemia, especially in elderly or in young women or middle-aged women, can cause a lot of neuropsychiatric issues, and fortunately, it's a treatable and curable disorders. And you can see hyper and hypothyroidism. If anything presents acutely, we can actually pick it up. But the problem is when it's apathetic, gradual, then the psychiatric diagnosis is given first, the endocrine diagnosis is totally forgotten. That's the reason why we are having this conference today, this topic. Please look for the secondary causes for your psychiatric diagnosis and rule out endocrine causes, which seem to play a major role with your mood disorders. So diabetes is a bidirectional, and I love to say triple D disorder, not your brazier size. Please remember that. It is a triple D is diabetes, distress, and diabetes, denial, distress, and depression. So in fact, 4D, I can say. So it's a bidirectional, abnormal levels of hormones. So it changes in appetite, suicidal thought, nervous anxiety, loss of energy, and depression can result because the patient is completely inactive, overeating, gains obesity, results in diabetes, if especially predisposed to diabetes, or the patient results in, again, bidirectional diabetes itself can result in depression. So the lady we can remember who had an excellent control, now for past 1 year, she has poor glycemic control. Remember that lady? So psychiatric disorder leads to non-adherence, poor glycemic control, increased micro and macrovascular complications. So that's a very important clue that we need to find. History matters. So here comes our female mental health, which really, I was so bummed out with this. So throughout your menarche, can you believe prenatal puberty, awesome days, golden days as childhood? Once you hit the menarche train, here you go. Increased risk for premenstrual dysphoric disorders. And as you do the pregnancy, increased risk for peripostpartum, postpartum depression. And then menstrual cycle. Throughout menstrual cycle, we all go through our mood disorders, PMS we call it, famous PMS. So then perimenopausal, the withdrawal of the estrogen again sends you psychotic, makes your husband angry with you because they are not no more what they used to love you anymore. So that's how it is. So unfortunately, so hallmark symptoms, it goes along. You can say that this has actually been studied, how estrogen, progesterone plays a major role in the mood disorders of women. And PMDD is the hazard zone which a child, since menarche, undergoes and underdiagnosed. Unfortunately, these patients are presenting often. I'm pretty sure our obstetrician gynecologist colleagues are seeing, our primary care physicians are seeing, but it's not being addressed. Unfortunately, it causes a major distress to the extent that they are unable to even carry out the daily life. So the important clinical history is cyclical history. It starts a couple days before the menstrual cycle, and it's so severe, but then it resolves a day after the periods. So that's very important. Clinical history is needed. Approximately 50% of the women undergo severe mood symptoms. Are we being diagnosed, treated for menopause? Unfortunately, no. Even if we approach, we are not given much. But we do have relief. I do recommend women to go for their treatment. There's so many ways to help yourself. You don't have to really live through severe menopause, and there is help. So anxiety, depression is very common. Again, we have very high risk, irritable moods and sleep issues, decreased libido, craving, but we can, besides lifestyle support, emotional support, we can go for treatment too. So, sleep. This is a topic of the past 15 years, and India is getting worse in it. Right now, did you know that there was a PCOD sleep disorder, phone, PCOD and sleep disorder? Phone, your smartphone for your kid is associated with increased risk of PCOD because of sleep disruption. This is an Indian paper published in India. So that's one other cause for, yet another cause for increasing PCOD prevalence in India, and India is going to be one of the country with the largest amount of PCOD patients, sadly. So cycle, why it is so important, the circadian cortisol secretion begins at 6 a.m. and you can see it's preparing you with the insulin secretion for the first meal timing, elevated testosterone, peak alertness, greatest cardiovascular skeletal muscle strength is 5 p.m. And as you go down, all this should shut down to allow you to have a deep sleep by 2 a.m. Peak lymphocytic levels are noted at that time to help repair your body. When are we sleeping? 12:30 in the night, 1 a.m. in the night. I have a shift system. No, I have to see this movie. I'm addicted to the phone. Yep. So, and again, we can see that female sex hormones, they are closely related to this, that results in all these disorders during, again, many different phases of our life in women, unfortunately. So all this results in severe psychiatric issues and decreases the quality of life. Look at that, almost practically all hormones are involved in it. So ghrelin, cortisol, leptin, insulin secretion, thyroid hormones, testosterone. So you take it, you name it, it's there. Pretty much it runs the show. So it's important to insist on a good sleep cycle. We had a patient who wanted to get pregnant. She was an IT professional, so very high risk for infertile PCOS, infertility, or irregular cycles. She quit her job. She reestablished her because she was doing night, 12 hours, working with the US company, and she quit her job. She went into 3 months of lifestyle changes, redid her shift sleep thing. Believe me, she established, she got pregnant, and she delivered very happily a happy boy a couple months ago. So it's all it took was just regulating her sleep. Case 7, 43-year-old female brought to psychiatrist for visual hallucinations, severe mood swings, insomnia, hyperphagia, recent onset of polyuria polydysphagia, recent recurrent vaginal candidiasis, UTI, and severe weakness, proximal muscle weakness. She had multiple bruises on her extremities, diffuse alopecia. We just had about it. It's a camel hump, course fair. We had a case just now. And she had severe psychosis. So what's the classical diagnosis? So Cushing's, yes. 19-year-old male seen for uncontrollable rage for the past 3 months. This is a case I just saw 3 months ago in India. This is in Madurai. And parent reported very obsessive about his body image, joined his gym 6 months ago, fanatically worked out for 2 to 3 hours. Severe, he broke out with severe acne, and he was very muscular. Unfortunately, very small testicle volume, and he had erectile dysfunction. Already, he did not have early morning erections. And what was the cause for this youth? Sudden change in his physical and mental health. Case 9, 40-year-old came for marital counseling. Wife reported the patient was very moody, irritable, not interested in sex. So he was diagnosed with depression, but then again, the psychiatrist was smart enough to send the patient because the patient reported facial and body hair growth loss, chronic fatigue, muscle weakness, foggy brain, loss of libido. He did not have any alcohol abuse, drug abuse, or obesity, no other thing. He did not have any trauma to the head, not on any medication. So what was the endocrine disorder that caused his anxiety and depression, an otherwise healthy male? Hypogonadism. The never talked about thing. At least I hope now men will take this up, like how women take up the menopause to come forward, because 40 and above, you are high risk for hypogonadism. It starts very insidiously. One of the major causes for mood disorders, and a lot of long-term complications are noted. Rarely, 60% of the men could even name the symptom of the male menopause or andropause, as it was used to be called as. So, do you have help? Yes, definitely you have help. You can see the primary hypogonadism, secondary various causes are there. You can have testosterone replacement and lead a normal life, definitely. And within the guidance of the endocrinologist, you can restore your health and lead a vital life. That's very important. Anabolic steroid abuse is becoming very common, and that's the case we just discussed with what are anabolic steroids. These are, you can say, designer steroids derived from testosterone, taken as oral or injectables, unfortunately. And patients, unfortunately, young guys who are very body obsessive image, want to build the muscles, results in rage. And most of these causes now for the lot of killings that is happening, road rage that is happening, all these are unfortunately drug use, not just mere cocaine. Please remember, it's not just mere cocaine or street drugs. Anabolic steroid use are one of the common causes for rage, especially testosterone is known to cause severe rage. So psychiatric manifestation, again, I have come down to this. So case one, can you tell me what's the one blood test that could clinch the diagnosis of the patient with significant memory loss, paranoia, irritable mood, and presence with right Colles fracture? One clinical blood test that can help this patient. Hypercalcemia. Yes. Patient had hypercalcemia of 12.5, and patient had a huge right inferior parathyroid adenoma. She underwent surgery. Within a year, all her psychiatric symptoms resolved. She did not have dementia. In fact, she was a one sprightly old lady who came back, oh my God, sharp as a tack. Yes, so it was hypercalcemia. 64-year-old male underwent surgical resection of meningioma, sudden deterioration. What could be the reason? It's neuropsychiatric, neurosurgical ICUs. We see it very common. So usually in neurosurgical units, they use very high doses of methylprednisone, intravenous methylprednisone, sudden discontinuation of intravenous methylprednisone, or improper transfer of IV methylprednisone to oral methylprednisone, resulting in withdrawal, steroid withdrawal, resulting in sudden deterioration of this patient. So 32-year-old psychiatric unit for severe panic attacks. And she was, what was the reason? Tachycardia, alopecia, abnormal protrusion, huge, hyperthyroidism, yes. So this is again treatable cause. Patient completely recovered, no more psychiatric issues for this patient. And a 65-year-old living alone. So yes, depression, because the patient was widowed a year ago. So she didn't want to live anymore. So she got her medicines, but she never took her medicines. Her daughter found all of them shelved neat on the thing, but she never took her medicines. She did not start, she stopped caring for herself. So bidirectional, remember, depression can lead to diabetes, diabetes can lead to depression or worsening of diabetic control. Remember, depression is one major cause. We addressed the depression, patient became fine, grief reaction, and the patient became fine. Patient is back to her very good control. So this is a very important clinching clue, was widowed and living alone. So 24-year-old marked depression, this patient cried, this girl just cried her eyes out in my office here in Madurai. Turned out to be severe PMDD, premenstrual dysphoric distress, dysmenorrhea, this patient. So she underwent psychiatric counseling. We helped her regulate her cycle. In fact, I put her on oral contraceptives, which gave the continuous, steady dose of estrogen and progesterone, prevented the peaks and valleys of the estrogen and progesterone, along with the psychiatric counseling and antipsychiatric medicine. With lifestyle changes, patient recovered completely. She's off her cyclic medicines, OCPs, the regulating things. She is really doing good. This child is really doing really good. And finally, 70-year-old with apathy, bloating, common endocrine causes for severe depression, hypothyroidism. Yes. So having said that, thank you for this wonderful opportunity. And sit back and relax. Enjoy the rest.